Good morning. I shall briefly describe double-level fixator assisted nailing for lengthening and deformity correction using straight intramedullary nails and rail fixators. The technique was written up in the Bone and Joint Journal in the February 2019 issue. It essentially enables us to perform two tasks, which could be lengthening, deformity correction, or arthrodesis for any etiology in the long bone segments of femur and tibia. Instruments needed are custom-made straight nails of the perfect length and diameter, polar screws, rigid reamers, specially designed entry point jigs, and the wide diameter of a C-arm. High-quality full-length X-rays are a sine qua non for the planning of deformities. I have a 90 cm wide C-arm which allows me to work accurately in the lateral view and with comfort and room to spare. Anything narrower makes the task rather difficult. Straight nails with custom holes in the center are crucial for this technique. Rigid reamers convert a curved marrow canal to a straight one. The bone can lengthen easily over a straight nail, and deformities can be accurately planned and corrected. Polar or blocking screws help direct the nail through a narrow path, help correct the deformity acutely, and prevent secondary deformities after surgery. Rosbrook's article in the JLLR described the reverse rule of thumbs to insert the polar screws. We designed this jig to gain entry at 81 degrees, which is the ALDFA in the distal femur. Other instruments needed are entry tubes over the guide wire and thin-walled reamers that go on top of the entry tubes. The entire set of instruments is made available by Manman India. We measure the nail size using X-rays with magnification markers strapped accurately onto the level of the bone and also on the C-arm a few weeks before surgery. Then we place an order for 3 adjacent lengths and diameters for that patient with central holes at calculated levels. Choosing the right portal is important. This is a severe varus bowing deformity and the patient cannot adduct the hip. It is difficult therefore to enter the piriformis fossa. Better to approach distally. A femur with a high neck shaft angle cannot be approached proximally without damaging the head, neck or vascularity, and we should start at the distal end. A distal entry is not possible in severe patella baja as in polio, and central growth arrest may cause a fish mouth deformity of the distal femur and narrow the intercondylar notch in osteomyelitis, and hence we are forced to start proximally. Osteotomies are done at the cora, but X-rays may sometimes deceive. The curvature may be greater than expected, and the apex may be found at a slightly different location in surgery. Ideally, the central hole should be between the two osteotomies. I admit I have often felt the need to be able to create holes in blank nails during surgery, clean them in an ultrasonic cleaner, and flash autoclave them for a bespoke fixation for strange circumstances. This 40-year-old had a severe Genu valgum with an intermalleolar distance of 36 inches and mechanical axis deviation of 240%. This animation shows a large valgus with MLDFA of 70 degrees. First, we pass half pins posterior to the track of the nail. At 81 degrees, a guide wire is inserted and starting tubes and thin-walled reamers over it. Polar screws go around on either side. A drill hole osteotomy is corrected with lateral translation with the help of the half pins and the reamers. The reamer is advanced to the next apex. The second osteotomy is performed and the deformity corrected and is locked with an LRS fixator. The reamer is advanced to the piriformis fossa, a lock nail is inserted, and the fixator is removed at the end of surgery to get an accurate desired correction. This shows the sequence of the guide wire at 81 degrees, the starting tube, the thin walled reamer, and the polar screws. If no deformity is to be corrected distally, the reamer is parallel to the anterior cortex. The blue pins are titanium and are inserted perpendicular to each fragment. They are more elastic than the stiff stainless pins and are more forgiving of fixation within the clamps of the LRS fixator because they are inserted freehand. The lateral translation of the distal femur and the medial translation of the tibia in the Elizarov fixator help to correct the mechanical axis from 240% to 51%, and his limb is completely straight. In the same manner, the opposite limb was also treated and a correction was complete. There are no limitations in function. He can sit cross-legged and he can squat down either to just rest or to the use of toilet, and hence he is a very happy patient. This is perhaps the benefit of having a very short or no fixator duration at all. Bow legs with multi-apical varus in the coronal plane are commonly seen in osteoarthritis of the knee. The elegance of the Indian sari also hides the severe bow legs and leads to neglect of the osteoarthritis. There is a large deviation of the mechanical axis with MLDFA of 104 degrees. The femoral deformity is present at two levels. This animation shows a bowed femur with a MLDFA of 104 degrees. 2 plus 2 half pins are passed posterior to the rack of the nail. At 81 degrees, a guide wire is inserted from distal with starting tubes and thin walled reamers over it. Polar screws are inserted, but here they are directed towards the lateral cortex. The distal osteotomy is performed and corrected with the help of the pins. The reamer is advanced to the next apex of the deformity, which may be at the anterior or lateral cortex. Second osteotomy is done and corrected with the fixator. The LRS is locked in place. The reamer goes above, the nail is inserted and is locked in place, and the fixator is removed till we are sure that we have a full correction. The distal portal was used to correct her femur at two levels. At a second stage, a medial opening wedge high tibial osteotomy completed the correction of the mechanical axis, and she has a straight limb. In a short while, the opposite femur was treated but was slightly undercorrected using the DLFN technique. The tibia was corrected with the double level TCVO using an Elizarov frame. 3 years after the surgery, she has straight limbs and is free from pain and can sit down to work at home as she wishes. There is a small 6-degree knee joint tilt on the left side, but the patient has no problems. But I am slightly unhappy about the outcome. This is a pediatrician who has a large procurvatum bowing in the femur due to poliomyelitis. The mechanical axis passes well behind the knee and pushes the knee forwards. The knee cannot be locked because of a weak quadriceps. The body has to tilt forwards or a hand has to be used to stabilize the knee. The gait is very ungainly and tiring. We corrected him with a distal entry nail with a very good posterior translation of the distal fragment in the distal osteotomy and a second level osteotomy also correcting the procurvatum. His knee is almost straight and it can lock passively in extension. He also had a supramalleolar osteotomy, which allowed us to correct his mild equinus contracture without resorting to soft tissue releases. These releases would have no doubt created further weakness in his lower limb, which we wanted to avoid. His deformities are resolved and he walks well without tiring and can work the whole day in a very busy pediatric unit in the hospital. The DLFN can also be used in non-infected trauma such as mal-non-unions and malunions. This businessman had an atrophic non-union of the femur with a varus deformity and some shortening. We used the DLFN with a distal entry nail and corrected the varus deformity, passed the nail further, and an osteotomy was done at the middle level. The central bolts locked the nail and the non-union site. 3 centimeters of length was achieved with the help of the LRS fixator. The non-union healed without any bone grafting, and he has regained most of his range of motion by now. External fixation duration was only 56 days. I suppose an alternative method of treatment could well be the chipping and then nailing treatment described by Professor Matsushita of Fukushima in Japan, with only a single focus of treatment, and would have probably been easier to manage technically. This is a common problem in poliomyelitis, and a supracondylar osteotomy in its modern avatar is. The closing wedge osteotomies performed in the past translated the distal fragment inadvertently a little anteriorly, and hence did not allow the center of gravity of the body to go significantly anterior to the center of rotation of the knee to lock it. In its modern avatar, the angulation translation osteotomy at the supracondylar level by Rule 2 mandates the posterior translation of the distal fragment. This makes it easy for the center of gravity to go in front of center of rotation of the knee and to lock the knee even in the absence of quadriceps or hip extensor function. The Ilizarov fixator permits gradual and full correction of large or moderate fixed flexion deformities in polio. It so happens that they have a significantly longer fixator duration, but we are rewarded by a full correction because it can be done gradually and without creating problems. But for the mild to moderate deformities, the DLFN allows us to achieve correction as well as lengthening in a really short fixator time. This slide shows the position of the polar screws and how they help the reamer and the nail to posteriorly translate the distal fragment to achieve a good correction of the fixed flexion deformity. A proximal portal is ideally used when the distal cannot, as well as when the procurvatum is more significant and more prominent proximally. In this diagram, we see that we pass the LRS pins posterior to the track of the nail. We start with the reamer, which is angled from posterior to anterior, and the first osteotomy is created at the apex of the deformity. Then the reamer is advanced to the next level. Efforts are made to translate the distal fragment posteriorly to comply with Rule 2. The distal and middle holes are locked and lengthening continues proximally, and when finished, the fixator is removed after locking the nail in just a few weeks. This slide shows what happens sometimes when we cannot achieve posterior translation of the distal fragment, especially when the distal apex is far away from the knee joint. In DLFN with a proximal portal, we must make an effort to have the distal osteotomy as distal as possible to avoid this problem. This young man, however, went on to get a small amount of lengthening and good correction, and he walks quite well and has full range of motion in the knee. Femoral recurvatum, varus and shortening is also seen in Ollier's disease. This is a 20-year-old lad who has a 33-degree varus, a 58-degree recurvatum and 18 centimeters of shortening in the lower limb, with 13.5 of them being in the femur. Using the DLFN, I entered proximally, pre-drilled the proximal corticotomy, and second osteotomy was performed at the junction of the normal and enchondromatic bone at the distal level. The recurvatum and varus was corrected by initially angling the LRS clamp into varus and recurvatum and then making it parallel to the proximal clamps. The distal and middle segments were locked and lengthening was achieved through the proximal corticotomy. The nail slid in and we got 10 centimeters of length. The patient came 4 months later after stopping distraction for the locking, so he had an external fixation index of 27 days per centimeter. He has a mild persistent recurvatum, however, he has full function in the knee joints and is very happy with the outcome. Unstable joints with shortening are a common presentation in poliomyelitis. This school teacher had a varus instability in her flail ankle and some shortening that led to a very disconcerting and painful unstable gait into varus in the ankle. The ankle and subtalar fusion was done from a posterior approach and a distal entry nail was done with a corticotomy lengthening in the distal tibia using an Elizaro fixator. The hindfoot was fused in mild equinus, so she also could stabilize her knee joint which was weak with some weakness of the quadriceps muscles. She is very happy with the result and has no pain and walks with less fatigue. DLFN is a fairly complex technique and many things can go wrong. It involves more OR time, more radiation exposure to the surgeon, and risk of complications compared to external fixation. We also need blood transfusions and higher antibiotics. Premature consolidation is possible, as happened in this young polio patient who happened to have a really narrow femoral canal. We used the smallest possible nail, but it still jammed in the proximal femur, and you can see the pins bending as we attempted to lengthen, but he prematurely consolidated at 1 centimeter instead of the 3 centimeters that he required. It also so happened that he was undercorrected at the supracondylar osteotomy site. When we use DLFAN or FAN with a proximal portal, as I have said before, it may not be possible to correct the distal osteotomy completely unless the osteotomy is closer to the knee. Another DLFAN patient who had a good correction of FFD and some lengthening developed stiffness beyond 60 degrees. It so happened that we used an older jig which was broader than the nail. This was done in the year 2009 and it did not push in the nail completely. So we solved the problem by removing the nail, performing a corticeps plasty and an arthrolysis, which gave him full range of motion and satisfaction. This 20-year-old lady with cerebral palsy had a varus malunion with mild shortening. Double level osteotomy was performed, but the maximum nail diameter possible was only 7 millimeters. Inadequate inventory also led to one of the holes overlapping at the proximal osteotomy site. This was the disconcerting picture she sent when she had a painful spasm which broke the nail without having a fall. Well, the trusted Elizaro came to the rescue and solved the problems and corrected the deformities completely at both the levels, and also gave her the 15 millimeters of length she lacked. She is doing fine now 10 years after surgery and has full range of motion. This headmistress with poliomyelitis also had an ankle subtalar fusion with a distal tibial lengthening. It failed to lengthen due to a loss of the distal fixation due to osteoporosis of the bone. Conversion to Elizarov fixator with an all-wire frame and a proximal lengthening reliably completed both the tasks, however with a duration of more than 9 months. I saw her 11 years after surgery and she's doing just fine. Finally, I would like to end my presentation with an example of double level lengthening with a single nail. This is a 30-year-old radiologist suffering from fibrous dysplasia who had a malunion and 12 centimeters of shortening in the femur. We performed a double level correction with a proximal entry. At the proximal level, the varus was corrected acutely to more than 30 degrees, and at the distal level, the compensatory valgus of 15 degrees was also corrected acutely. The distal fragment was locked with bolts. The middle and the upper fragments were left free. We chose to allow the soft tissue tension to decide which osteotomy would lengthen how much. As we used the LRS fixator to lengthen, the nail slid in and he achieved 9 centimeters of length in the femur, 4 of them proximally and 5 distally. When the nail was locked centrally and proximally, the bone formation was very sparse and almost invisible. He followed up with me only 2 years after the locking because of the corona problem and the lockdown, but we find that the bone had matured completely without the need for grafting. He was walking with crutches in the interim and left them on his own when he felt that the bone was strong. He is now a consultant radiologist with almost equal leg lengths and a central mechanical axis with 120 degrees of knee range of motion. In summary, using simple instruments like straight nails with extra holes, rigid reamers, polar screws and the LRS fixator, we can perform 2 tasks in one segment with less fixator duration, lower costs and ease and comfort to the patient. I thank you very much, Team Hull, for the very kind invitation to participate in your landmark conference. I wish I could be there in England to enjoy the glorious summer. Thank you all once again.